we are back, and for this first, the brain is the master component of your CNS, and there are 12 pairs of cranial nerves, as you can see on this picture. On the right, I always have the cadaver, and same style, guys. So again, for my exams, I think so far the feedback was okay. That whenever I do practicals, I will always just only use the cadaver images that you'll see. I will not change anything. It's going to be exact images that you'll see with an arrow. As far as the content questions, they'll be very similar to the applications that I post every week. So I hope you guys are pretty comfortable with me now, right? So I know Shrikar, you always ask me like, what's on the exam? How's it going to be? Or you guys are going to be a little stressed last semester because I only had 2 or 3 sessions. But moving forward, just expect very similar style from me. Review the applications, review the cadaver images, and that should cover most of your content. Everything else is bonus. The more you study now, it's only going to make your first year of medical school easier, right? MCAT is not even close to what you're going to see in the first year of medical school. So once you're in, you also want to do well. I learned of a very unfortunate stat when I came back 2 weeks ago on campus. I think there's 2 students in our first year that are retaking the year. So that happens, okay? So just FYI, that does happen. I also heard in the last summer that one of our third-year students dropped out. So the worst thing I think that could happen to any student, that breaks my heart, and I feel bad for them because I feel the stress. I can't imagine what kind of stress mode they'll be in, is once you committed to medical school and you have to retake a year. Usually what happens in the retakes is if you fail a course twice, okay, but by that I mean remediation. So if you don't pass the remediation exam, and that does happen, okay, so we don't ever talk about it, but let's say 160 students come into medical school, maybe 2 or 3 in the first year may drop out or repeat. Currently in our cohort, there are also 2 or 3 students from the second year that are repeating. They should have been in their second year, but they're repeating in their first year again. Okay, so just FYI, keep that truth in the back of your mind wherever you go. That could happen. So what I'm trying to remind you is every time you're studying for these content, you're just getting better so you cover your grounds. All right, everybody good? I know it sounded kind of depressing, but that's the truth. I want you to know what could happen and so why you got to put the time in. Okay, so the 12 pairs of cranial nerves. These nerves are going to be from the brain, and they command the different special senses of the body, a couple of muscles, but they're divided into sensory or motor. We will dive them a little deeper next week. I'll go into each of the nerves, tell you their function. We'll create a mnemonic. One of the better mnemonics is going to be knowing the nerves. So there, you can see the letters are olfactory, optic, ocular, motor, trochlear, trigeminal, abducens, facial, vestibular, cochlear, glossopharyngeal, vagus, accessory, hypoglossal, and spinal. So all these nerves have 12 pairs. They have different names, different sensory or motor function, or both. And we'll get that next week. So we'll start our story today with a little bit on the overview of the brain. I love the brain. I think this is one of the most fascinating topics in the anatomy physiology courses. And a snapshot here, you'll have the left-hand side. This is an inferior view of the brain. You see the eye, you see the optic tract that crosses over. There's a little region called the chiasm. This is the crisscross of the left eyes going to the right hemisphere, and then the right eye going to the left hemisphere. So the crossing over occurs right at that point. That's also right above the region where you have that core diencephalon, where the thalamus is sitting. The famous hypothalamus is also located right in that region. Then as the nerves cross over, it's going to go towards the posterior region for occipital, and that's where you have visual processing. So on the right, this is another view, just from the outside. Again, all this stuff will make sense. I just want to show you these big folds you see. These are the gyri. These little invaginations are called sulci, and they look like this big, massive, lumpy ground meat texture. The brain is divided into several lobes, which we'll take a look at. You have the frontal, you have the temporal towards the ears on this bottom lobe right here. We also have the occipital in the back, and then we have the parietal on top. Okay, so a lot of the terminology will start to add up in a second, but I just want to show you what we're going to be working with. As we go through the lecture today, we will also go into the brain, and we will look at some of these specific nuclei. The brain is so complex. Okay? If there's one piece of the body that we can still learn and make discoveries, it's probably the different kind of nootropics, receptors, different kinds of neurons and how they interact. When I go over the brain, what we'll do is we're going to break them into segments. For example, the basal nuclei, the limbic system, the hypothalamus. We're going to break it up, but in reality, they all work in one system. Okay, so it's hard to look at it all at once because there's so much going on. But we're going to open them up. And so every time we go over a set of structures or a region of the anatomy, just know that it could intertwine with other structures. Most of this stuff you can't see with your naked eye. One of the highest specialties, and if you decide one day down the road you want to pick specialties, right? Some of the cream of the crop, right? Dermatology is pretty good. Neurology, neurosurgeon, that's like the apex. There's levels as well when you go into medicine. And I'm sure if you guys follow some feed, you'll see like family. I mean, again, all MDs, DOs, great job. Training is amazing. But once you're in the field, you realize if you want to be a neurologist one day, that requires like another 8 years of training or 6 years of training versus if you're a family practitioner, that's like 2 years. The amount of content knowledge and the amount of training, there's differences, right? So there's gaps there. So just, again, the brain is super complex. I don't have all the answers. If there's anything that you're curious about, I could always try to ask. But I'll share with what I do know. Over here, this is a pretty good view. So we're going to look at this quite a few times. This is sagittal view. You cut it through, split the brain open, and you can see a few things. I'll just share that there's one structure that I hope we start off by saying is the corpus callosum. This is a big little network that links the left and right brain. And there's a lot of studies, and this is already justified, that females tend to be better multitaskers than males, okay? And the reason is because the average corpus callosum for the female is actually bigger. There's actually more fibers in the brain than in males. So if you were to have every variable perfectly controlled, technically, if you compare a male and female, the female will be better at multitasking. It just, there's a slight anatomy difference. Also, based on your dominance, if you're right-handed or left-handed, there's this phenomenon called patelleus, which you can't see here, but that patelleus is when the brain actually, the lobe, will enlarge on the side that you're dominant. So if you're somebody that's ambidextrous, you want to be a surgeon one day, that'll be a good training to have, just to practice both hands. If you're a gamer, again, a lot of studies show that gamers actually, if a surgeon is a gamer, play video games with hands, their hands are a lot more delicate, more dexterity. They tend to make less mistakes. Pretty crazy. So again, it's a lot of the hand-eye coordination, how well your fingers move, and how you control. Okay, so we'll start our story off with just a few layers. So we'll start from the outside. The brain, the spinal cord, is outer protected by a layer. This is the cranial meninges. The meninges is like a cushion, a connective tissue that's going to separate the bone and the brain. There's a lot of vessels in there. You might have heard of some of the layers before, but the 3 layers of the meninges is going to be the pia mater. That's the most inner layer that's closest to the brain. Then we have a sublayer called the arachnoid mater. This is the layer that's going to be webby. Arachnoid sounds like arachnid, like a spider. So the spider layer with all these fibers. And if you look at the picture, inside the arachnoid layer, there's these little webby fibers. This is a trabecula. And you can see it's cushioning the brain to the skull, right? You're thinking the brain is sitting in this armor of the skull, and it's a hard osseous tissue. What happens when you shake your head? Is it going to slam on against the solid matter? Well, no, you want to have some cushion. Then the most outer layer that you may have heard of is called a dura mater. Okay, let's give you a clinical application here. So you might have heard of different kinds of subdural hematomas. If you have an accident, you hit your head, that's when there's a leakage or CSF or blood pooling in that area. Most of the time, whenever any of the meninges is damaged or has a potential herniation, a kind of tear, the fluid that accumulates will swell. That fluid is mostly blood and CSF. Have we heard of something called CSF before? Cerebral spinal fluid. So that's the fluid that cushions the brain. It's generated through a set of structures called the ventricles, and it flushes through your spinal cord to reduce some of the ions, maintain the sodium-potassium ion content, washes out dead blood cells. But the whole point is it cushions your brain. It's a detoxification fluid. It's actually thought that, and again, some of this stuff is still debatable, but it's believed that when you're in REM sleep, between that deep sleep, that's when your brain actually will secrete that. There's a set of cells called the corpus plexus that actually will flood it. So as you get older, and as these cells start to get a little bit less active, or if you're cutting your sleep, so earlier we were talking about sleep, if your sleep is horrible, you are compromising the CSF's ability to flush. And that also directly relates to your brain health. So if you want better memory, you can't be running on like no sleep. It just won't work. And then on the outer layer, the tougher outer layer, we have the superficial parasodial layer. That's the most outer layer, and then the meningeal. So I just want to highlight over here, the dura mater includes the parasodial and the meningeal. I know it's been a couple of weeks, but just a refresher, when you see my slides for this next couple of weeks or for the semester, always focus on the things that are highlighted. Make sure you know the terms, right? Again, anatomy is just strictly a list of terminology. So if you still haven't really found the best way to study, and I know everybody's level is different, right? Everybody's study methodology or how comfortable you are is different, but I want everybody to do well. And the tip for everybody here is start to make a list of terms that you see, or maybe if you're reading a slide and you have a PowerPoint or note, just write the terms out. Make sure you know what they are and what they mean. Okay, don't just pretend to see it and skip the slide. All right, so make a list, and then you can always come back to this. All right, now inside the brain, there's also going to be several support structures. These are going to be called this dural layer septas, and these dural septas are like sinuses. These are films that help anchor these different components of the skull. I highlighted a couple of these. So the first one is the phalanx cerebri. This is going to be the kind of the partitioning film that goes between the right and left hemisphere. So if you were to divide the brain up, and this is a tricky one because most of the structures, it's better view in a three-dimensional view. We'll have it later for the. And by the way, do you guys hear about the update? So HoloLens is kind of getting extinct pretty soon. We're kind of I think the company isn't going to be making updates, and so we're transitioning on either sticking with the HoloLens or maybe potentially getting the Oculus. So pretty cool stuff. So maybe when you guys start, you guys knew the one from Apple.
Apple Vision?
Is it? Oh wait, is Oculus Apple Vision? I forgot the name. It's like the big. It looks like the ski goggles. Yeah, it's pretty cool, and then it was pretty nice. But it is very tight though. So it's versus the HoloLens. There's a little bit more air. That one just like glues onto your face. So if you have glasses, it kind of hurts. I had to try it on. It's like if you have big goggles or big glasses frames, it's gonna squeeze onto your face. Anyways, okay, so the next one is the tentorium cerebelli. This is going to be the horizontal partitioning between the cerebrum and cerebellum. As I'm going over the structures, just a heads up, we'll come back to different layers and different regions of the brain. The cerebrum is the outer partitioning of the brain, outer components that process higher power order thinking. You have memory, the conduits for somatic sensory and motor. The cerebellum is located where? The back, the lower inferior. It's actually the second largest component of the brain. It contains different kinds of neurons. One of the ones notable is called the Purkinje. They're mostly used for motor and gait control. So when you think about the ability to have muscle tonus, right? Muscle tonus is the ability for your muscles to still have some ability to contract and maintain tension when you're relaxed, right? So when you're sitting right now on the chair, there's some fibers that are still contracted. That tonus is maintained by some of these areas of the brain. When those areas get damaged, you get flaccid, right? Literally, it just kind of relaxes and you have zero tonus. And then again, other parts are used for integration. So when a signal comes in and you are wanting to move your body, signals have to apply an action potential to reinforce either kind of a contraction signal or maybe inhibition and that fine balance. Then we also have the falx cerebelli. This is going to be the partitioning within the cerebrum and cerebellar regions. And then the last one, which is super important, is a diaphragm celli. This is the one right here in the picture in the middle. Any guesses of what structure it protects? Well, it's actually shown here. Pituitary. What's the function of pituitary? We've probably heard of this before, but this is a component of the brain, but what's the function of your pituitary?
Regulates growth hormone, GnRH.
Okay. Really good. So you throw in a couple ones. So GnRH is short for this gonadotropin releasing hormone. But the pituitary gland, this little P gland right there, that's literally in the middle. If you had to put like the middle of the brain, that's probably closer to diencephalon, but right there, this is going to be the master endocrine command center. So it controls what we call the flat pig. Flat pig. Flat F, FSH, FL, L is LH. Actually, I can write it out. Where's my board? Oh, the board's there? Okay, let me just, okay, I'll move this. And by the way, thanks to Christina, right? You rearranged the room for us this morning. So before you came in, literally all the tables were everywhere, so she moved it. So give it up. Thank you. Okay, cool. So one mnemonic, I mean, you guys know, like, when you're doing anatomy, the best way for one is always going to be mnemonic. So there's a pituitary gland. One thing I'll just start. We'll come back to this. It's called flat pig. You got to know this one. All right, then F stands for FSH, follicle stimulating hormone. We'll go over this a little bit more, but this is the main hormone that stimulates the receptors to spermatogenesis, oogenesis, or sex cell development. L stands for luteinizing hormone. At one point in time, they called it ICSH. This is the old name. Interstitial stimulating hormone. They don't use that anymore. ICSH is the old term. So if you're using an older book, they might use that. But this is luteinizing hormone. This hormone is what stimulates the sex hormone. So androgenesis, androgen production, estrogen, estradiol, estriol, the sex hormone production. A is ACTH, adrenocorticotropin hormone, and this is the one that makes something called could be a cortisol. Okay, so it's one of the glucose regulator, the stress hormone. T, thyroid stimulating hormone, TSH. P is prolactin. That's for lactation, nursing. And I is this inhibition. There's nothing over there. There's no I in G growth hormone, which is also known as IGF. Okay, that's actually the functional component. So IGF, insulin growth factor, is what actually does the function of getting your cells to get large. In the liver, growth hormone is just a signal. Okay, but this is just a snapshot of some of the key hormones. So whenever you think pituitary, just remember P. Okay, these are the hormones that's gonna come back. All right, so over here on the right, you can see just some of the pictures. In the middle, we have the tentorium cerebelli right at the partitioning where my mouse is, the cursor is showing. We have the falx cerebelli on the posterior side, and the falx cerebri over the entirety of the area. Okay. Now, of course, the brain is still not just cushioned by these partitions. There's a couple of other stuff that helps hold it together. These sinuses are empty cavities that serve as drainage of fluid. And what's important is that when there is concussions or contusions to the brain, you always hear about these hematomas or kind of swelling in the brain. And these pockets are good because they help drainage. But at the same time, when patients have hydrocephalus or like a subdural hematoma, these pockets are where the fluid accumulates. And you will have to alleviate them. So there are some surgeries where they go in to kind of drain the fluid out if there's a rupture. But here are some of the sinuses. Don't stress out about too much about these, but here's some of the layers. So we have the dural venous sinuses. We have one on the superior sagittal region on top. And if there's a superior, you probably can guess we have a inferior, right? There's going to be a component there right below it. So superior on top, the inferior right on the bottom. And then, of course, from the left to right hemisphere, we have a transverse, which you can't see in this 2D picture. And then one in the back that we oftentimes don't realize is we also have a septal sinus in the back. Very small little thin gap. This usually happens whenever people fall backwards. And oftentimes when there's a concussion from the back, the occipital sinus can oftentimes get swelled with fluid, squeezing the component, building up the intracranial pressure. That will then lead to the brain being squeezed and potentially rupturing a vessel. Yeah, question? They're tubes of cavities, yeah. And most of the time they have the ability to drain the actual venous fluids, any kind of excess, but these are open cavities. But at the same time, when you have a concussion or physical injury, they can swell up. And then that can cause intracranial pressure to then squeeze the brain. That's why anytime you get a fall, literally any kind of incident, the first thing you protect is your head. You don't want any pressure changes in your brain. You don't want any kind of potential squeezing of the pressure, and that's going to compromise your brain. So it's so delicate. And then that's why usually when I do this open brain surgeries, as they cut through the meninges, these sinuses are places where naturally they should drain fluid, but if you have a blockage or a swelling, the fluids can't drain out. This is outside of the CSF. CSF is made in the brain itself. You can see the brain is not here, but inside the brain, they're the ventricles. That's the internal fluid compartment that we'll see in a second. But these are all external. So we're kind of working from the outside slowly into the brain. Here's the real picture. This is pretty cool. So take a look on the left. These are, again, I'm a big fan of the cadavers. I think just seeing the real thing paints a picture 10 times better than just a cartoon. But you can see over here, when you dissect an actual human skull and a head, you'll see the film. So the dura mater is pretty thick, right? You guys can see that, just how thick the layer is. So after you cut the skull, you then get the dura mater. Then when you get into the dura mater, you will have a thin film called the falx cerebri before you can peel into the brain. If you've ever seen there's a couple of documentaries on Netflix talk about like Alzheimer's and Parkinson's, and they show some of the actual intracranial experiments. When you layer out the skull and then you take over the dura septa, then you see a film. That film is a cerebri. On the bottom, you'll see all the different layers of the vessels of these veins. And then right in the middle, this is that diaphragm and sella. It's super small, but this is what houses. It's literally the saddle on top of your sphenoid bone. So if you remember last year, we went over the skull briefly, right? You guys went over the skull briefly. Okay. We'll probably touch on that a little bit later on this semester, but there's a bone in the middle of the skull called a sphenoid. It looks like a little Batman sign. It has a couple of wings. It has a greater wing, lesser wing, and it's actually right here. It's right in the middle. That bone contains most of these openings, the foramens that allow the nerves to pass through. That's also where your pituitary gland sits. So it's like the smack middle. And oftentimes when there are tumors that could occur that could grow around these areas, the pressure occurs here and then potentially causing hormone dysregulation. It can cause blood flow changes to the brain. Very, very tragic. Okay. On the right, this is a cartoon image that's showing you, again, we have the sinuses, this thin film, the falx cerebri, that's the film partitioning, tentorium cerebelli on the bottom, and then the falx cerebelli right in the middle, left and right side. So this is a posterior view of the head. Removing off the skull, and then you can see the actual film and then exposing the brain. All right, so this is all external protective layers. Not much to protect your brain, to be honest, if you think about it, right? So that's why if you are somebody that, was there like a bike rider? Who was the rider here? Jade? Yeah, if you're riding motorcycles, always, right? Always protect your head. Get the best helmet you can buy. I'm a big advocate because I grew up in Taiwan. Everybody has mopeds, and then they do tests on different helmets. Some of them are just absolute like fake ones. They have styrofoam in there. It's like nothing. So just always have a good helmet if you're riding a bicycle. Every time I see a bicycle, I always say that. I was like, "Where's the helmet?" My wife gets so annoyed about that. Okay, so over here we're going to the ventricles. So ventricles are the cavities within the brain. They secrete the CSF fluid, cerebrospinal fluid. A total of 4 ventricles. This is a pretty cool structure that oftentimes a model, I think we do have some models that you guys can run out, but we'll do the whole cadaver thing in the HoloLens. But the ventricles look kind of like a spacecraft. If you look at the purple structure outline on the right, it looks kind of like a big, if you're a Star Wars fan, like a TIE fighter kind of thing. It has a little TIE fighter style. There's the left and right ventricle. That's your first and second. Right in the middle of it is the third ventricle. And to join them together, there is a small little opening that you can't see, this aperture called the interventricular foramen. It's a small little hole that you can see on the left and right side, not anteriorly like you see on the picture. And that drains the fluid as it comes down. Then we have the cerebral aqueduct that leads into the fourth ventricle. So this is literally a component of fluid drainage, like a tunnel in the brain that helps you create that fluid cascade. It then washes down through the spinal cord, comes back up. But there is a connection to all of them. Okay, so between the first and second is the interventricular foramen. That's the joint. Going from the third and fourth is your cerebral aqueduct. That's what links them together. Some books will refer to this as first ventricle, second ventricle. It doesn't matter, left or right. It's usually just the lateral ones. The third one will always be in the middle, and then the fourth one is at the brainstem. You could probably just say with accuracy that the fourth ventricle is right at the pons of the brain / the brain stem. So pons / medulla oblongata and the brain stem. So it's the stalk of the brain. It's almost at the bottom. Okay. So just again, the picture isn't the best here, but you can see it. Take a look on the right. So this is a pretty cool image. You can see it looks kind of like a big spaceship. It has the big wings, like a TIE fighter from the Star Wars. The lateral ventricle is the first one and second one. The third one is right in the middle, and then the fourth one comes all the way down. Key functions of this, as we said before, it helps provide protection, cushion to the brain. It also has buoyancy, so it reduces the weight of the brain by a significant amount, so it's going to be cushioned there. The main key structures is that it's outlined by a set of cells called the choroid plexus. These are a type of neuroglia. Let me paint this picture for everybody. When we go over the brain, there are 2 kinds of cells, 2 families of cells. Neurons, which are able to generate an action potential or nerve signal. They're the ones that fire the signal to get the nerve cells to fire, release neurotransmitters. You hear about neurogenesis and potential and memory. That's neurons. The second type of cells that we have, or family, is called neuroglia. These ones are the astrocytes, oligodendrocytes, epidermal cells. These are the resident, they're not the conducting cells, they're the resident kind of environmental cells that play the role to generate the environment. And then within that type, the epidermal cells, which is kind of the barrier, they're kind of like a cuboidal hybrid cell that will then form the outline barrier. So that stuff just can't go into your brain, right? You don't want viruses or anything that comes into your system to go into your brain. So that epidermal cell serves as a layer. There are some notable viruses you hear about, like the shingles, herpes zoster. Those ones reside in the nerve roots. They literally stay in the roots of the nerve. So those can actually reside inside those cells. Okay, so like the shingles, right? So if you have the chickenpox as a kid, herpes zoster is one, and later on in life, that means a virus is laying dormant in your nerve roots. When your immune system gets weaker, it can outbreak out and cause you to have then the shingles outbreak. And it's a very unfortunate. They actually have a new vaccine now, which is really good. They've been pushing it since last year. But if you have elderly in the home, definitely over 55, 60, definitely just it's worthwhile. I think it's pretty expensive though, if you pay out of pocket. All right, so here's a picture of the choroid plexus. You can see zooming in. These are small little cells. They look kind of like a cuboidal ciliated cell. They outline these little courses of the blood vessel. There's the capillary. This is the pia mater, the inner layer. And then this is what fills in. So this is the real one, okay? So the real ventricles look very different than a cartoon one, but you can see this is a preserved cross-section. So they take the brain, they slice it frontally, you open it up, and you look into the ventricles, and you can see the tubes. It's like a little hollow tubular structure, almost like a wing on left and right side, drains to the bottom, and this is the fluid that we said before. So when you're getting that nice quality deep REM sleep, your body actually generates it. And that's why a lot of studies are harder to do because they can't just go into the brain and look at somebody sleeping. But there's some studies that do point out that CSF is only generated when you are in REM. I don't know the science and physiology all why that happens, but different organs will detoxify different times. And during that time, that's why when you wake up and you have a good sleep, your brain function is usually at a better acute level. Okay. There are some times where you're going to have to pull like a all-nighter kind of thing, right? But it's not sustainable for sure. Okay, so as far as the flow goes, this is good to know. So we'll start off with the choroid plexus. That's why I highlighted. That's the structure in the brain. That's the anatomy, the ventricles. It usually flows and gets generated through the lateral left and right, so first and second ventricle, floods through the interventricular foramen, down to your third and through your cerebral aqueduct, then to the fourth. The way I write this out is because it helps you remember the flow of the fluid and also the anatomy. Okay, so just remember left and right, laterals first, then the interventricular foramen, that's the opening that connects the two. Then we go to your third ventricle. Then we go down to your cerebral aqueduct. That's going to be at the brain stem and the pons region. And then your fourth ventricle at the bottom. Okay, so it's 1, 2, 3 in the middle, 4 at the bottom. And then eventually some of that will then flood back. So you can see the picture on the right. It's pretty cool. It shows you that generated right in the middle, floods down to number 2 towards the cerebellum, that big kind of tilted Christmas tree on the right. This is the cerebellum. These are the longest cerebellar fibers. You have the different arbor vitae. It's like we call it a tree of life. It looks like a big Christmas tree. It comes down to number 3. It floods across the brain back to the sinuses again and goes down the spinal cord. As it then returns to the anterior segment and drains through the cella turcica around the diaphragm cell A and goes around the brain. So it literally cycles around. There's a flow by which the fluid moves. And that flow is very important. Again, there's still a lot of research being done on some of the function and when it gets secreted, the amount, why does it, but the flow, there's a certain sequence of fluid generation that happens in your brain. I can't tell you why that's the flow, but it goes from the ventricles down towards the posterior side, returns on the anterior, and floods from the frontal back into the center. Pretty cool. Maybe down the road you can tell us something to find out. Cool. This is a zooming into that layer. So this is what we're working with. Small little arachnoid space. We have that little gap right there with the films. These villus extend out into that sinuses where the fluid can actually drain. So as the fluid's going through, these villuses provide any kind of extra sodium or potassium that your body doesn't want to dump out, any kind of metabolites, and that's usually the flushing of the brain. Also, certain kinds of nootropics, certain kinds of neurotransmitters, recycling of chemicals, but namely, I'll say that it's sodium-potassium balance. Sodium generally is going to be a little bit higher on the extracellular side, and potassium is always going to be higher on the intracellular side. Maintaining that gradient ensures that your nerves can fire a signal. Okay, you probably have been covered a little bit of that already. I don't know the exact time you can cover the physiology for the nervous system, but you should be aware that in nerve cells, to preserve connectivity, the sodium content is always high. It's more positive on the outside of a cell than on the inside. That allows the cells to then depolarize by allowing the sodium to rush in. If you block that sodium channel, then the nerves cannot fire, and as a result, the nerves will not be able to send a neurotransmitter. Okay, so sodium on the outside, potassium on the inside. All right. Oh yeah, go for it.
So, arachnoid villus, is that like a part of the choroid plexus?
So arachnoid villus is along the arachnoid mater. There's going to be little extensions that protrude out, and as the fluid goes through, it can pick up stuff. So it's kind of like little hairs, but it's very small to see. So this is just
protrude into the dura
into dura.
Or through the dura, I guess.
It literally goes through the dura, and then it's actually touching some of the CSF. So as the CSF goes through, it has a chance to pick up any nutrients or release compounds.
Okay.
Yeah, and then if you guys maybe heard of the epidural, when you go to labor or any surgery, epidural kinds, and these are very, very big breakthroughs when they decide to go to surgery, is providing the epidurals through that is by injecting the chemicals through into that layer so that it gets into the blood cells and then that reaches the nerves. So it's a very powerful way, especially like a lumbar puncture, when they go in and then you arch, you basically inject the compounds into the meninges of the spinal cord, which is nice and big. You don't want to put it in the brain, right? They probably tried that at one point and it didn't work out. But it's like, okay, well, let's go between the lumbar because there's a gap. You bend over, you could penetrate through the film of the meninges and deliver the drug, and that drug can still get to your brain. And when it gets to your brain, it makes you not feel the pain. But you can best guess that years and years ago when they were doing research, they probably tried different areas. They probably tried, let's try the thoracic area. Oh my God, that probably doesn't work well. Let's try the cervical region. Oh my God, it's even worse. And then maybe some crazy doctor or scientist decided to try the brain. Like, let's try to inject the compound in the brain and see if that can deliver it faster. So lumbar seems to be the best choice. All right, cool. Let's do a few more slides and we'll take a break. So let's start with the brain because the brain is super extensive. This is a very cool topic. Again, I can only just cover the stuff that I can accurately tell you that I know from the textbooks. And this first segment of the brain is the cerebrum. Because now that we went over the skull and the layers, we're going to take open the cranial cavity. We're going to peel out that falx cerebri, and now we're going to get into the brain structures. The very first component of the brain you'll see is called the cerebrum. Okay, that's the outer kind of lumpy, bumpy structures, and this is the functions of analytics, the processing of higher mental functions. You have these folds called the gyri, these groups, and then the deep fissures that kind of cascade around. One thing I do want to highlight is that the brain is partitioned to different sections, but in a cadaver, it's obviously not color-coded. Right? So you get the frontal lobe that goes with the frontal section of the skull. We have the parietal on the lateral side. We have the occipital on the back right here on the bottom, temporal right by the ear, and there's one more lobe that you can't see. There's a lobe called the insula. The insula is actually hidden underneath the parietal and temporal. So that's the only layer or only lobe function, dedicated function that is not visible to the outer surface. Okay, so again, there's 5 lobes or 5 sections. We have the frontal, oh, actually I have it right here. So frontal lobe right here, parietal lobe, occipital lobe, the temporal lobe, and then underneath, if you tease open the parietal lobe and the temporal lobe, then you see the insula. Each of these lobes will have a different function. There are some overlaps, but the general function of your cerebrum is to be able to exhibit different kinds of higher order learning, interpretation, processing sensory stimuli, motor responses. And each of these are not easily going to be identified because there's some that are overlapping. So when I say that this brain area has this function, there could be some areas where they're overlapping. Okay? It's not just one structure in the brain does motor integration and one area is only for sensory. There's a number of structures that overlap and there could be still changes. On the picture here, just kind of going over this introduction, is the frontal lobe is used for a couple things. For motor speech, namely here, there's one area that you have to know. In the frontal lobe, we have something called the Broca. You guys see that? It's a small little term, Broca. The Broca area, is the main function for processing of the muscle command for phonation. So when you're trying to speak, the controlling aspect, the conscious control for your larynx, your tongue, your mouth is the Broca. There are patients when they have certain kinds of aphasias, where they lose the ability to speak or to understand, depends on that area. So if you have Broca-based aphasia, that means you can understand the language and you can hear what people say, but you can't express it in words. Same thing goes if, let's say you have a very, very unfortunate case of Huntington's disease or Alzheimer's and progresses through, and your speech starts to slur a little bit, that's usually when the Broca nerve cells get damaged. Yeah. Yeah, most likely. I mean, I think it depends on the severity of how it progresses, but most likely you won't be able to phonate, so you probably will be choking more when you're eating or drinking. You might also have to have a rhythm. Most of the breathing, though, is more diaphragm control, and that's going to be the pause. So if you look at the brain here, none of this area is for the vital control center. So heart rate, respiratory rate, your breathing rate, the diaphragm control, that's going to be your pons and medulla oblongata. That's a little bit lower. But for speech, usually when you're trying to express a word or say a sentence or say a term, you won't be able to do that. And just with that, on the right behind it, there's a little region over here that's bubbled out called the Wernicke. You guys see that? The Wernicke. That's the other component for speech interpretation. So this is the one that's right between the junction of the parietal and temporal lobe. You can see right here between the parietal and temporal. I know the color is a little throws you off, but it's honestly, I think, one of the most important ways to start visualizing the brain is with color. So when you see the models of the brain, before you look at just the raw cadaver of the brain, start with the color so you know where is the primary somatosensory cortex, where is the frontal lobe, where is the insula. That way you have an idea of where you're looking at before you see this lump of a mass of a tissue. And then the Wernicke is used for what? If Broca is for the physical muscular control of speech, Wernicke is for comprehension, hearing, audition, the auditory component. So that's exactly the two components. So that's why those two areas are highly studied. There's so much speech therapy science, so much research done on the components of Broca to Wernicke. So let's say you heard a language before, you have a second language as a kid growing up, going to school, you don't use it, but the moment you hear that language again, an area of the brain starts to get more active. Parts of the limbic system, parts of the Broca might recall, versus if you never heard of something before, like let's say you've never heard the word cerebrum. And I said the first time, today was the first time you heard the word cerebrum. What other aspect of the brain gets lightened up and is a different component. And so what happens here is that when you have the auditory component, the Wernicke, and you have the speech component combined, you could have a stronger connection, a stronger potential to recall. And that usually links to a region called the limbic system for memory. So if you're somebody who likes to read out loud, that's actually pretty good. I had a couple students that I know all over these years that tended, I always ask them, you great student, what's your study habit? Do you like to write? Do you like to just listen to lecture? Some people like to read it. And when they read out loud. So you're reading because you're activating your Broca. You hear it again with the Wernicke. So you're reinforcing that concept over and over. And then there's also people that have photographic memory. So those people do exist. They literally just look at the picture and then they can just write it out again. So again, whatever works for you as you're transitioning from this program to medical school, make sure you learn what's the best way you can take in content, whether this is new content or old content. Okay, so just 5, yeah, take it. Exactly, yeah. So when you have the Wernicke-based aphasias, usually what that means is you can't understand what's being told to you. So the language comprehension gets reduced. You can't put the sentences together. There's no meaning, or what you say comes out with no meaning, right? You're not putting the nouns and the verbs and the way the sentence flows together. And whereas the Broca is going to be where your speech is slurred. So, it's all good. Is that a duck? Oh, nice. Okay, it's basically when you're slurring your speech or your ability to almost phonate is compromised. You can't speak or make the sentence or the sound of the word. Wernicke's might be more fluent and not understandable, but Broca is non-fluent. Yeah. Good. Over here, the 5 lobes. So just be aware, insula, right? That's the secret one. You can't see it. So if somebody asks you, where can you identify the insula, you have to open up the parietal and temporal. So over here, this is a deeper dive on each of the sections. So frontal lobe, this is going to be the region that's going to be on the interior part of the hemisphere. Most functions here, and again, take it with a grain of salt. Number 1, voluntary movement. It also allows you to have concentration, verbal processing, communication, decision-making, planning, personality. I wouldn't say it dominates all of the memory and the emotion states, but some personality gets influenced in the frontal lobe. The parietal lobe is going to be right behind it. That region is connected a little closer to your ears, your auditory canal. This region is going to have some functions of understanding and integration. So the most important two is the primary somatosensory. So every single nerve input that you feel from the body gets processed right at that middle region called the primary somatosensory cortex. Then in the front of it, you have the motor cortex. That's the response. The general kind of rule here for the brain is that the upper hemispheres of the brain coincides with the lower parts of the body. So your feet sensory signals receives on the upper part of the hemisphere of the brain. The lateral component on the lateral sides, those ones are further up. And then one more thing I want to highlight is that your whole body is absolutely not at a symmetrical proportion for nerve senses. Some areas have a lot more heightened sensitivity. So your nerve precision, your lateral precision, your 2-point touch test, and your fingers, your gonadal region, the bottom of your feet is a lot higher, more acute than the back of your leg and thighs. The majority of your somatosensory cortex is dedicated to your face. Your face has the highest surface area of interpretation on that cortex. Okay, and this is usually indicated if you look at an anatomy book or a physiology book called the homunculus. It's like the little character. It looks like a little exaggerated anatomy of a human being, and the lips are huge, the fingers are huge, but the body's small because of the surface area to the nerve ratio. Then we have the temporal lobe. This is going to be on the lateral sulcus underneath the temporal bone. Primary function is hearing and smell. Let's talk a little bit about smell. So smell is the only special sense. This is the only nerve signal of the brain that does not have to go through the thalamic tract. So every sense that we have, vision, hearing, taste, feeling, pain, out of all those sensory general senses and special senses, the sense of smell is the only one that bypasses the thalamic tract, which means that when you smell something, it could trigger memory the quickest. It is the absolute quickest shortcut to memory. Okay, so if you did a test and say, hey, did I see this slide before? What class? What year? Versus did I taste this food before? At what restaurant? Or if you smell something that triggers fear, the best way to trigger something is by smell. Okay. All right, and then occipital lobe for the vision cortex. So this is for visual information, stores visual memories. It does not process all the relay, but it stores the memories. And then the insula, which is the one that's hidden, is a combination of emotional states as well as taste. This one is one that has been uncovered a little bit later in the studies of neurology, and this is pretty fascinating because a lot of taste and motion can link together. And again, some of these receptors serotonin, right? So that's why I always joke with this is that if you're somebody that after you eat ice cream or eat a piece of cake and you're still miserable and you're angry after eating ice cream, something's wrong. Something's wrong. The serotonin receptors aren't working for you, or something isn't processing, and so forth. All right, so let's pause there. We'll take a quick break. We'll come back and then get some water. Pause this recording. Yeah, I know. It looks like you guys need a stretch break. So steps, and so now that we've finished introducing some of the external structures, before we go into the deep dive on specific nuclei, let me show you this quick picture. This picture is very significant to understanding how the brain's primary motor cortex and primary somatosensory cortex is divided. Earlier, I said a few things. I said the body is not evenly distributed with all the senses and motors. I also said that right in the middle of that parietal lobe, there's this region shown here, kind of tinted in the violet color, and then on the right, this red color. This is going to be the two strips of the cerebrum that are dedicated for interpreting all of the information from the body. Looking at the picture, what do you guys notice? Number one, the upper parts, the superior regions of the cerebrum, coincides with the close it. This one. And there's like I think the door is open. But when you look at the picture, you'll see two things. The first part that you should be able to recognize is that the superior regions of the cerebrum coincides with the lower parts of the body, right? So your toes, your ankle, your knee, your hip, this is going to be at the superior aspect of the hemisphere. As you transition towards a lateral aspect, it goes up the body towards the upper upper arms, all the way to your face. Another thing you should see is on the left-hand side of the somatosensory, the motor cortex, is that right here, look at the distribution of what area of the cerebrum is dedicated for what part of the body. Your face, your lips, your tongue, your pharynx, this entire area spans a majority of that aspect of that cortex. On the right side, you're going to see the somatosensory. So over here, same thing, genitalia, your foot. Such a small aspect for interpreting sensitivity of the feet. So if you got bit or a little ant is crawling in the back of your calves, you probably won't notice it. But if it was crawling on your face, you would instantly recognize that sensitivity. As it goes down, it goes to the lateral side, the trunk, the neck, the shoulder, all the way down to your face, your teeth, your lips, your gums, your tongue. And one thing that we'll see next week is that the special senses, which is going to be comprised of your vision, your smell, your audition, hearing, your balance, equilibrium, and then those key senses, those ones are majority controlled by the cranial nerves. So of the 12 pairs, you're going to be seeing that about 6 or 7 of these are dedicated just for your special senses. Okay, and then that's very, very uneven, right? It's not symmetrical. Over here, just highlighting, we already went over in the primary motor cortex. We have a speech motor area, the broca, that's used for muscular controlling of the vocalization, pharynx, your tongue, your lips. The Wernicke is going to be for comprehension. And then over here, corresponding to each lobe, is the cortex. This isn't too hard. The visual cortex is in the occipital lobe in the back. The auditory cortex on the lateral side will be in your temporal lobe. The gustatory, that's for taste, that's in your insula. And the olfactory cortex is in the temporal. One thing we did say is the olfactory is the only one that bypasses your thalamic tract. So that means it does not get to relay to any other part of the brain. It goes from smell, olfactory bulb in your nose, olfactory nerve, cranial nerve number 1, plus you directly to the amygdala and the limbic system. Okay, so the tract of signal is super quick, very short. As a matter of fact, one of the easiest access to the brain is through the nose. If you do pituitary surgeries or tumors, one of the easiest ways to access the pituitary gland is through your nasal cavity. Okay, over here, then we have the white matter, so some more anatomy. Along the brain, there are integral structures that link up the brain's hemispheres, and these ones, you can't see externally, but these are called the central white matter. The white matter corresponds with the neurons are myelinated with the oligodendrocyte. There's a thick, fatty insulation that allows the signals to fire quickly. And we have 3 kinds of bundles of these neuron fibers that attach them together. So you'll see the brain has the gray matter on the outside, but the white matter is on the inside. This is exactly the opposite of your spinal cord. Spinal cord will be flipped around, white on the outside, gray on the inside. So there's a transitioning of neuron types. The first kind of axon bundle that we see is called the association tract. If you look at the picture, you'll see association tracts are going to be the ones that go within the lobe. So they're localized in one area only, specifically in one region of the cerebrum, on the back, the parietal lobe, frontal lobe, etc. Then we also have the commissural tracts. These examples include the one that we said earlier about the female versus males, the corpus callosum. They attach the entire hemispheres. There was a lot of mysteries about the brain years ago when they first, 10 years ago, they're like, oh, we don't use all the brain. There's a lot of powers in there. All the brain is used. Only different activities might be localized at different times, but every neuron circuit can get utilized. Then we also have projection tracts. These are the ones that are a little lower. They anchor the brain, the cerebrum, down to the lower hemispheres of the spinal cord, medulla oblongata. But over here on the right, you can see a little color-coding picture of arcuate fibers within the lobe, the corpus callosum attaching. Think of this as more the infrastructure that link the brain together. Now, the cool part about the brain is we're going to move from the structural component to the actual functional nuclei. So the next couple of slides I'm going to share will have specific cell nuclei that I want you to associate with. And I will probably say the anatomy is knowing which nuclei goes with which structures. For example, you may have heard the most famous one is called the basal ganglia. Basal ganglia. That's going to be a region that's dedicated just for dopaminergic and motor control. The famous disease is the lesions of Parkinson's. That's whenever any of the basal ganglia, and there's like 4 or 5 components. There's like the putamen, the globus pallidus, the corpus striatum, the caudate. These components are all within that series of nuclei. Okay, so what you're going to see is I'm going to go over. This is actually, you can see some of it already. If you take the brain and you slice it frontally, take a look at the picture. First and foremost is we have these fibers, the association fibers, projection tracts. And then notice in the middle of the brain, there are these darker colored regions. These are called nuclei. When we say nuclei in the brain, we're not talking about the nucleus of a cell. These are bundles of neurons that have very similar function and have similar receptor expression. We do not know all of the receptor types, but we do know that there are similar receptors packed together. So when patients have a reduction or reducing of those cells, the ability for that area to perform that function gets compromised. And so, for example, in Parkinson's, what's the most noticeable symptom that you see when Parkinson's has? Tremors. Basically what happens is the body, the brain, inside the basal ganglia, any part of the component is not able to initiate a contraction, or if they do, they hypercontract. Usually you have a situation where I want to move my arm, but I can't. Or if I contract my arm, I hyper-exaggerate. And that's called tremors or chorea. These are exaggerated contractions. Oftentimes, it could be depending on how the disease progresses, on which side. Is it ipsilateral on one side, or has it already progressed on both sides of the body? Okay, we'll talk a little bit more on that later. So this is the first one, the first key structure. This is, again, a lot of highlights, right? A lot of highlights, a lot of things that are in bold. That means it's important. Is cerebral nuclei, aka the basal ganglia. Years ago, I think they used. Honestly, I think it's both fair. If you use like another book, they might call cerebral nuclei. Another book might call basal ganglia, the same thing. But this basal ganglia, basal nuclei, is a mass of these key gray matter located in the center parts of the brain. And the 5 key components are as follows. The corpus striatum. This is the region that's used predominantly for motor integration. Okay, motor-based skills, integration signals that are coming in. The second one is going to be a subnuclei called the caudate nucleus. You can see it's on the left and right side, right on top. What I would recommend for anatomy here, and this is my tip for you, is you can either start by going from top down. So if you look at the brain, the only way you can really clearly see the structures is if it's frontal lobe. So cut it like this. So do you want to, you can start by memorize, or just, I won't say memorize, just knowing the location from top down. So on top superior is the caudate. Going down the middle, then we have the thalamus. On the lateral sides, we have the globus pallidus, the putamen, and the most lateral side is going to be, so the most inferior side is the amygdala, and the most lateral is claustrum. So you can see closely that it kind of, you can go from top down or from middle out. Okay, just like the muscle, right? If you're memorizing which layer, top down probably is my better tip for you. So going top is going to be the caudate first, and then the amygdala is on the bottom. And the amygdala body is also overlapping with another series of nuclei called the limbic system. Okay, so let me just refresh this. What I said in the beginning of today's class is that we're going to look at the brain in different sections, but they all work together. Some of these functions will overlap. So when I say an area is used for motor control, it's not the only one. Okay. The amygdala body, what you need to know is this is the dominant center for emotional states. So emotions, raw behaviors, mainly fear, arousal of fear, and that kind of emotion states is going to be amygdala. Then we have the sub-2 structure called the lentiform. I just like to call them by the single parts. It's called the putamen and the globus pallidus. Let me highlight the difference. The putamen is for most of the kind of physical motor control, but the globus pallidus is mostly for muscle tonus. Okay, so the difference is that motor control is when you action potential to cause the muscles to contract. Muscle tonus is that when the muscles are relaxed to maintain the tension in the fibers. So it's a fine balance. That's why when you think about being able to perform a dance, or if you want to just pick a pen up and write, you don't take for granted how much precision occurs in the muscle fibers. When you have a patient that has Parkinson's or Huntington's that progresses through the basal ganglia, they won't be able to hold a pen or stay stagnant. As a matter of fact, you won't be able to raise your arm. You would either hyper exaggerate or you just can't even move it up. Okay, that's one way to think of it. And the last one of the basal ganglia is called the claustrum. This is going to be information for most of the sensory stimuli coming in. If you look at the picture, it's on the most lateral aspect of both hemispheres. Okay, that thin little line you see right there, it's a little bit darker. This is the claustrum. So the key components are corpus striatum that connects it together, caudate nuclei, this is for walking and gait, amygdaloid for emotional state, lentiform, the two parts are the putamen and the globus pallidus. If you really want to get into the weeds, the pallidus is divided, some of the research shown it's actually divided into 2 substructures called the internal pallidus and the external pallidus. We're not going to worry about that here, but if you're curious about how motor controls, or if you know somebody that has Parkinson's, this is the area of research. It's not just any one, it could be any one of these components damaged. So lesions that occur here, very tragic, right? And again, is there a cure? Is there a cure for Alzheimer's or Parkinson's? Or just think about it. Is there a cure if the cells are damaged? Is there any drug, any kind of pharmacological intervention you could give a patient to fix that? No, you can't. It's all receptors. So when the cell degrades, the receptor fades away. That means giving them more dopamine, or usually the treatment is all dopa or dopamine. Would it help to give somebody dopa if the receptor that binds dopa isn't there? That's what's happening. So most of the times in neurological tragedies is because we have drugs that are compounds, analogs of the nootropics or the neurotransmitters that are given to the patient. But the fact of the matter is when the nerve cells are damaged, you have nothing to bond. So even giving them higher dosage of L-dopa dopamine, it might be just comforting mentally, but it's not going to fix the problem. That's the truth. Okay? All right, that's the first one. So cerebral nuclei. This is a pretty cool picture. It's highlighted, kind of color-coded in orange. So just looking at the picture, the caudate on top, amygdaloid on the bottom, right? So if you're going from top down, and then there's a little kind of wedge kind of from inside, so from the most medial to the most superficial, you have the globus pallidus, putamen, and claustrum. Okay, so however you like to orient that thought process, either from outside in, inside out. Remember, GP, putamen, claustrum. GP, putamen, claustrum, caudate on top, amygdaloid on the bottom. So it's like the 4 or 5 structures that form the basal nuclei. Are we still good here? This is the first one. Okay. All right, next structure that we have, this is the real one. So if you don't appreciate the cartoon, especially the brain with the colors, when you see a real one, you can see, first of all, the brain isn't the same lobe size. It's a little bit more shriveled together. There's no color coding. You can see a little bit of hint of that darker matter in there, but it's not as easy to make, right? So when you see this cadaveric images, take a look at the cartoons. It will benefit you to go back and forth. I really like how these slides are shared because you can see the cartoon and then bam, the cadaver, right? So you can see it right there and just compare it. All right, the next structure is going to be your thalamic tract, so diencephalon, midbrain. 2 components here. The hypothalamus is going to be at the roof of the diencephalon. This is the mid part of the brain. And then within this, I said a structure called the thalamus. The thalamus on the right here is a central region right above the hypothalamus. The thalamus contains a couple of substructures. One is called the interthalamic adhesions. These are the midline dividing left and right side. There are so many neurons in here that we can't go into all of them. But in a general snapshot, we call these the thalamic nuclei. Okay, what's the main function? This is the relay hub for the whole brain. So every single sense that's consciousness, except for olfaction, has to go through the thalamus before it goes to one of the cortexes. Everything. So every visual cue, sensory cue, taste cue, pain perception, routes through your thalamic tract before it goes to how you perceive it. And then after that, then it gets stored into the memory system of limbic. Memory is a fascinating story. I can branch out if you want to hear a little bit, but there's one component called LTP, long-term potential. That's based on the sodium and magnesium contents, and that's how you store long memory. The way it works is the more you reinforce the signal, the receptors get generated. So there's this receptor called AMPA receptors that get embedded on the cells, and when you trigger that circuit, you get more receptors. So the more you do something, the more repetition, the more you have a signal that can retrieve that information. It's pretty crazy. So there are receptors in the cells that have to be embedded. So this is the key ones. I have a mnemonic here to help you take a look, but I already made it simplified. So this one is going to be the vicious lovers meditate, always venturing laterally. Again, take it if you want to use it. The key nuclei that I pulled out are 6 of them. You will hear them later on again in neurology. The first one is called ventral anterior nuclei. This is only used for motor control, motor planning. There's 2 lateral geniculate and the medial geniculate. This is important. These are for the reflex arcs for vision and the reflex arcs for hearing. So this is also why when you see something and you remember maybe seen it before, called deja vu, you've seen it before, but you don't quite remember exactly where that was. There was a memory reflex that caused that to happen. And then maybe the storage in the occipital lobe wasn't super strong, but it was there. Then we also have the anterior lobe. This is going to be the memory and emotions. And then the 2, probably most critical one is for sensory, is going to be the VPL and VPM, the ventral postlateral and ventral postmedial. Okay, don't worry about all of these, but what I'm showing you here is that if you were to take the thalamus out, it's a big kind of olivary oval shaped structure. And if you were to cut it open, each of these different sections have different neurons. Different neurons mean different receptors. Slightly different neurotransmitters. Okay, so even though it's one thalamus, it's really like thousands of different cell types combined together. That's why the brain is so complex. It's not like, oh, the thyroid gland. Thyroid gland is just follicular cells, and you have the thyroid follicles, that's it. It's like one thalamus, but it's composed of all these subthalamic nuclei cells that are very different. Okay? As far as what you should be associating is when you do see any of these geniculate nuclei or the ventrals, think of thalamus. Okay, so whenever you see a ventral nuclei or any kind of geniculate, automatically associate that to the thalamic tract. That's the thalamus. Are we good? All right. So I know it's a lot of terminology. Make a note card. Look at it a few times.
So we should be able to match, like for example,
Yeah.
geniculate to that diagram.
Yeah. So what I would say, what's valuable, you won't need to know this picture. This won't be on the practical, but what I would say will be valuable to you is one day you're going to see a question and say the patient has shown that there's a lesion inside the geniculate region of the brain. If you don't know this, you're like, what the heck is geniculate? That's inside the thalamus and is inside a region that's used for processing of vision or hearing. So I would say just associate these key terms with this main structure, like the umbrella, right? So basal ganglia has those ones, the caudate, GP, putamen, claustrum. The thalamus has the ventral anterior, geniculates, lateral medial, and also the VPL and then VPM. All right, and then the next one, which is a super master class, is the hypothalamus. Okay, you can't go over the brain without this one. I love this one because this is the command center for endocrine. This is what they call a tier 1 system. This is where all the hormones get controlled from the hypothalamus to the pituitary, then to the gland. The anatomy for the hypothalamus is fairly straightforward. The main region, if you look on the right, is there's a stalk called infobitulum. There are 4 key nuclei that I would like you to know. This will tremendously help you. One is called the paraventricular nucleus. We call it the PVN. If you're ever curious about research, they usually abbreviate them PVN for short. The second one is called the preoptic area. They call this the POA. And then the next one is the suprachiasmatic nucleus. This is called the SUN, SCN. And then we also have the SOA, which is supraoptic. So these are the 4 main ones. Yeah, I'll have a next slide. But if you look at the picture, just don't worry about taking all the notes because this will be recorded. But look at the picture here, guys. If you look at it, again, the hypothalamus is a small little triangular region right above the pituitary gland. You guys see that? It's a small little, very small, very tiny, very small little section that is right above your pituitary stalk. And that little juncture is called the infobitulum. Within this infobitulum, there is a series of the hypothalamo hypophyseal blood vessel. It's a very small capillary bed that allows the hormones from the hypothalamus to quickly flood across. Why do you guys think it's all color-coded? It looks kind of like Skittles, even though the red dye is banned. Why is it color-coded? Does it mean it's different or the same?
Different.
Yeah, so all these cells within that smaller region are all different. Okay, so for example, the paraventricular nucleus right here on top, this is used to release hormones like CRH and ADH, antidiuretic hormones. Very different cell type. That's why when they study this area, it's very different types of receptors and cell makeup. Some of the overall arching functions, in case you didn't know, the hypothalamus, number 1, controls all the ANS. So all the autonomic system is controlled here. Master control for endocrine, that's a key one. It controls body temperature. Usually, anybody know when your temperature drops the highest or drops the lowest in one day? When do you have the lowest body temperature in one day? When you're sleeping, yeah, by about 1 degrees. So about 36.5, 36.4 degrees. But when you're awake in the morning, it's about 37, depending on the environment what you're doing. But that's controlled by your hypothalamus. A lot of times pyrogens when you get a fever. Bless you, this is also the main site for fever control as well. So when you get a fever, pyrogens affect this region. Emotional behavior, food intake, sleep cycle. We'll talk about circadian rhythm maybe later on. But the pineal gland is connected to the hypothalamus as well. So the moment you open your eyes up or the moment light penetrates your eyelids, that triggers the retina to fire signals through that optic chiasm to the hypothalamus, which will then hit the pineal gland. And that then begins the melatonin and lighter days. So that's why if you're getting bad sleep, you have to be in dark room. You have to avoid any light penetrating your eyelids. Okay, so these are the 4 nucleus. The first one is the PVN, paraventricular. This is releasing a hormone called CRH, corticotropin releasing hormone. This is the predecessor to, on the board, I wrote ACTH, right? You guys see that? ACTH is the 3rd one. That's the predecessor to ACTH. It also makes a hormone called the ADH. We'll talk a little bit more about endocrine when the time comes, but the way we can think about this now is that the pituitary gland is what releases it to the body, okay? Between the hypothalamus and the pituitary, there is a tier 1 control. So if a patient comes in and their gland in the body is perfectly fine, chances are the disease is inside the brain. So that's why they call it primary or secondary. The term primary, some kind of disease like primary hyperthyroidism. primary oversecretion of the gonad hormones. Any primary means it's the gland itself. Whenever they say the word secondary, that means it's in the brain. Okay, so if you ever get a diagnosis or come across a term as a secondary, usually that's the diseases inside the brain stem or inside the hypothalamus. And then the second one is preoptic, POA, that releases the GnRH. I think, Bryce, you were talking about this one. This is the hormone that's a predecessor for FSH and LH. So on the flat pig mnemonic there, that's the predecessor for those two. The third one is called SUN, supraoptic nucleus. This one actually releases ADH. So what does that mean? This one doesn't generate it. This is where it releases out. And then the SCN is suprachiasmatic nucleus. This is the one that controls circadian rhythm. Okay, so there's a lot going on. This is another smaller mnemonic. People play sports smartly. So PVN, POA, SON, SCN. Okay, so associate the nuclei with the structure of the brain. I think that's the best way. If you don't do that, it's a mess. The brain is a beast in terms of anatomy and knowing what does. Is so much going on. That's why I always think neurology is, if you want to take the challenge one day, please go to neurology. Don't do family medicine. Don't do, we need neurology. We need some of the people to rise. We need those. And then the next structure is the brain stem. So brain stem has three regions: the midbrain, the pons, medulla oblongata. On the right side, I'm teasing it out by itself so you can see it a little bit more clear. Again, there's a number of structures. There's actually a new, only like 5 or 6 years ago when they were doing the physiology and anatomy book updates, they realized that within the pons, there's over like 100 different nuclei. Like the red nucleus, and there's some, if you look at an older book, they literally don't know the function. So this is the only topic when you look at an older anatomy book. Let's say you have a friend or know a doctor that went to school in the 80s, their textbook would have a lot of information missing in this chapter. They would be like, oh, what's the function of the red nucleus? It is currently unknown. It writes that in the book. It's really not often you'll see that in textbooks nowadays, but there were times where a lot of this was unknown. The brainstem's main function is for vital cardiorespiratory centers. It's mostly for the vital signs. It also is for wakefulness. So a lot of times the very first adrenaline, first of the kind of the booting up, the activation of the brain begins over here. So we'll take a look. So within the midbrain, a few things I want to highlight. We have this cerebral aqueduct. This is that ventricle that we went over, so this is nothing new. We also have series of the main nuclei for the cranial nerves. I won't go over that today. We will do that next week. But if you had a guess, majority of those 12 pairs of nerves, they exit from this area. So you may have heard of folks that are in a vegetative state, where their brain activity is active, but there's a disconnect to the brain, or maybe if you're in a night terror or like a nightmare, but you're like sleeping, and your brain is active, but your body is disconnected. This is usually that juncture between activity and conscious control, aware of the environment signals to the brain's processing ability. The two that we'll point out is the ocular motor, that's cranial nerve number 3, and trochlear. These are all used for movement of the eyeballs. So in some patients, you might see rapid eye movement of the eye because there's activity through here. And then there's also the cerebellar peduncles. This is a juncture between the midbrain to the cerebellum. Okay, so this is where motor control and also the respiratory breathing. So again, that's why there's a lot of studies that show emotional states can easily trigger the changes to how your body breathes, how your body secretes hormones. Right? So you're thinking, why does being emotionally stressed affect your cortisol? Emotional stress is amygdala, some of the memory components. Then the hypothalamus controls your ACTH and CRH that can then raise your cortisol. So there are connections that we fully don't understand the pathway, but we know components are active in each of those areas. Then we also have a region called the tegmentum. Tegmentum is the junction between the cerebrum and the cerebellum, and probably the most important one is the substantia nigra. This is going to be the dopaminergic highlights of the brain. All the dopamine center that makes you feel the reward, feel good, feel motivated, feel attentive is right here. And this is also oftentimes a culprit in Parkinson's patients because the L-DOPA transition to dopamine begins from phenylalanine. Phenylalanine goes to tyrosine. Tyrosine goes to the L-DOPA dopamine. And any guesses what after dopamine? Epinephrine. So it's norepinephrine, adrenaline. So that's one reaction apart as well. So that's one reaction, which means your body's awakefulness and being able to stay awake on task is based on dopamine and adrenaline. There's also a small region called the tectum. This is a region that kind of houses the colliculi. I won't talk about this one, but if you're curious, this is for also auditory visual reflexes. All right, so that's your midbrain. Take a look at this picture. You take the midbrain stalk and you cut it across. Same thing, right? A lot going on over here. It looks kind of crazy, like some dark centers, and then it's symmetric left and right side. But just be aware that each of those little regions that you see that are tinted different color have different kinds of cells. Right in the middle, we have the cerebral aqueduct. That's the opening. The tectum is on the back. Over here in the bottom or inferior on this view is going to, this is the anterior, so this will be actually posterior view. Right in the middle is a tegmentum. And on the anterior view, we have the peduncles. And you can see right here the nerve roots of ocular number 3. Okay, so this is the one, oculomotor moves the lateral rectus, the rectus of the eyeballs. Okay, take a breather. And then one more key structure we're going to talk about is the pons. Okay, so right below that brainstem, connected to the spinal cord, is a pons. And this is usually associated together with the medulla oblongata. And then this region, one of the simple ones is think about breathing. So earlier somebody was asking about what happens if you can't phonate or can't control your larynx and your lips. Can you have an alteration of breathing and your diaphragm and your breath rate? Well, the main pontine respiratory centers are located right here. The structures that I'll highlight is called the olivary complex. We're not going to, again, dissect all of that, but the olivary complex is what controls shallow breath versus deep breath. Okay? There's two kinds of breathing. One is called the eupneic breath. Eupnea, that's a shallow, rhythmic, kind of chill breath that you're breathing right now. And then there's also a breath when you go into higher elevation or running, you have to activate a deeper breath. The rate of breath happens within a set of neurons called the VRG, DRG, but they are regulated by the olivary complex. So just remember this. Pons, think about breathing, think about heart rate. Think about when you climb a mountain and then all of a sudden you have to acclimate to the actual amount of oxygen around. That takes time. Your brain has a process how quickly you got to breathe, how deeply you have to let the diaphragm relax and contract, all that kind of stuff. Okay, it's all the rhythmic. And it also houses several nuclei of the cranial nerves, the trigeminal, which we'll talk a little bit more next week, cranial nerve number 5. Abducens, again, another muscle controlling for the eye, and then the facial. The facial is a beast. This one's subdivided to the V1, V2, V3. We'll go over that next week, but it's different divisions of the face and then also parts of the neck area. But these are the main 3 nerves that come from this region. Okay, so again, if there's any kind of damage to the brain stem, the pons, you're probably going to be in a vegetative state where you can't perceive sensory, but your brain activity is still going on, but you can't receive information because you can't move your eyes, you can't move your face, that kind of stuff. Over here, zooming in, this is a kind of a transparent view of it. You can see the pons wrapping around the big bulge. The medulla oblongata is right below it. And then within that region, you can see this kind of hollowed, lighter colored oval. This is the pontine respiratory center. Okay. We're not going to go into all these different nuclei, but I do want to associate which ones go to which. So whenever you hear about breathing, associate to pons. All right. The last one that I have here is the medulla oblongata. Okay, and this is, again, one of those powerhouses of all these different neurons. On the right, let's start with the picture first. You can see there's a lot going on. The color is kind of lightly shaded over behind each other. There's a little purple region or red region. But this entire area is predominantly used for respiratory centers connected. So some of these examples are the inferior olivary nucleus. This is a combination of proprioception of the body and also gait balance. There's 2 tracks. Think about the spinal cord's connection to the brain. This is where it begins. There's the NC and NG, nucleus cunatus. This is going to be for most of the perceptions of the upper body. I would probably say about T6 and T7 above. So think of that number. Anything above T6 is nucleus cunatus. Everything below T6 will be nucleus gracilis. So that's the track that fires the signals up. So when you hear about people that have neurological damages, you have a car accident, or maybe a baby is born and you want to test the reflex of the baby, make sure there's Babinski signs, make sure that the lower motor neurons are able to get to the brain, you will test for that. So just remember, NG, gracilis, is T6 and below. Cunatus is T6 and above. Then we also have some of the cardiac centers. This is the what regulates your vital signs, your heart rate. Vasomotor centers for the blood pressure. And out of these ones, the ones that probably have the most impact for breathing is going to be your medullary centers, and then within that we call it DRG, VRG. DRG stands for dorsal root base, and then the VRG is the ventral root. And these ones are what control the shallow breathing. Okay. If you had to differentiate these two, and there are differences, DRG is for quiet breathing. We call that eupnea, EUPENEA. And then VRG is for both expiring and inspiring. So it's a balance. So whenever you're curious about this, think about the first time you go up in altitude and your body feels like you're gasping for air. Right? Maybe you never ever hiked before, and then one of your buddies went to the Sequoia Mountain, and he goes climbing all the time. He's more acclimated. His VRG, DRG signals are way better than yours. You walk a little bit, and you're like, I feel lightheaded. I gotta stop. I'm gonna pass over. That's because you're not acclimated with that signal. The signals aren't commanding to accommodate for how much oxygen your content is getting, your blood cells, and you're feeling a little bit dizzy. Okay? I know that's a lot of stuff, but as you're going through the reading, as you begin studying this semester, again, just focus on the yellow stuff. I won't, everything on my questions, on my quizzes or exams will be stuff that we do on the applications. I want to expose you to content so that you have heard it once here, or maybe you've heard it before. So the next time you hear it at the medical school, you can take a little deeper dive into that. Okay.
So as far as like these terms, would you say it's better to make the connection of location? Like obviously everything's on the dual avant-garde, but would you say it's better to just know they're there, or to like know function of each?
Good. So I will probably say the only one to know the location will be the basal ganglia. That one's very clear, clean cut. This one you can see on the right side, medulla oblongata. Even with their whole lens, it's going to be kind of hard to see because a lot of these nuclei, they overlap. The nuclei could be right here anteriorly, and the right anterior lateral is the next nuclei. It's almost impossible. So you would never get. I've never seen any question, even in medical school, where they ask you identify the location of this nuclei. Unless you want to go to neurology, we need people that can do that. Then that's exactly why I think it's so valuable. Is that when you get into that next level, when you get to specialize, we do need doctors that have that neurology specialty, and that is the apex. That's like the cream of the crop. If you're a doctor that can go into brain surgery and know exactly which nuclei is the location of the disease, you are you're the best. Yeah. Okay. But this is why, because when you see the structure, it's all kind of blended together. But for this class, let's do this. Make sure you know which structures go with which main big part of the brain. So medulla oblongata houses these things. You don't need to identify them on a picture.
So we don't necessarily need to know nucleus maxillaris is perception of our body.
I think that's pretty fair. I think that the base function I think is pretty good. I already simplified it quite a bit. There's some overlap, but I think knowing the brief function and the location to the big structure, I think that's pretty good for here.
Just know the function of each one, and they're all in the
medulla. Yeah. Is that fair? So again, I know this is overwhelming. Normally, this is always going to be the most confusing topic. Even again, the first year medical school, the neurology average is always the lowest because a lot of stuff you can't see it, and a lot of stuff is so blended together that you don't know. And then the function kind of overlap, right? A lot of these functions like motor integration, sensory integration, there's a lot of overlap in terms of different parts of the brain. Okay, all right. So the last one before we do the lens here is the cerebellum. Okay, so we worked our way through the brain. Cerebellum is that big, massy second largest part of the brain, this mass right behind the stalk. And if you tilt your head, it looks kind of like a tree. This tree-like structure, kind of like Christmas tree, even though Christmas is already passed, is called the arbor vitae, the tree of life. This is the most longest single nuclei of the brain. The cells located here are actually very famous. They're called Purkinje cells. These are the single longest axon tails, axon hillocks of all the brain cells. The anatomy here is simple. When you take this part out, it's divided into the anterior lobe, posterior lobes, and then we have the different cerebellar hemispheres. The middle dividing border, there's a little bump right here called the vermis. This separates the left and right sides. And then these little ridges, they look a little bit different than the brain itself, but these long lines are slender across. These are called folia. These are folds of the long neurons. If you really get interested about the fine detail of fine motor control, so the basal ganglia begins the input. The cerebellum does the final tweaking. Think of it like this. When you learn to dance for the very first time, you're probably able to move your arms or move your legs just like the teacher or the dance instructor. But to fine-tune it with that fluidity is your cerebellar control. A lot of times the final command comes through here. Most of the time alcohol, some drugs affect this part, impairing ability to move your body. But it's because of the connection of this area to all the other parts of the brain. So if you look at it, it touches the brain stem, it touches parts of the pons, it touches all the way up through the cerebrum. So signals are not a one-directional flow. It goes back and forth. And so when you're learning to dance for the very first time, like you're trying to do a TikTok dance, the first time you do it, clunky. Even though TikTok is going to be by pretty soon, right? And then so the next time you learn to dance, you get a little bit more fluid, you start moving better, and then you see it again, your body begins to know exactly how much contraction you need to do to get that motion to go. So arborvitae, tree of life. Within the deepest regions, if you cut open, there are these cerebellar nuclei, and their main function are to control the fine tune. Okay, and then before we do the lens, this one doesn't really have a structure, but this is the memory component of the brain. I'll come back to this as we go into the cranial nerves, but just to expose you to this, if you're thinking about memory, think about short-term memory, long-term memory, how does the brain store information? There is a region that's dedicated just for learning and then for the housing of content. This is the limbic system. Within the limbic system, one that's overlapping is the amygdala body, right? The fourth one that I have here, this is the one that I already overlapped with basal ganglia, but the hippocampus is this big seahorse kind of ring-shaped structure right here. And this hippocampus is what allows you to store long LTP. I won't talk about this right now, but just know memory, hippocampus, and within the hippocampus, it's the broader structures of the limbic system. Okay, and that's it. Let's do that for now. Any questions about all the structures we went over? Let us sink in. I know it's a lot to take in, and then we'll come back. I know it's kind of like, oh, like throw you with a lot of content, but take a look at it, browse through it. We'll stop there, and then if you have any questions as you're going through it, let me know. I'll set up the lens. Let's take a look at the structures of the brain through a three-dimensional view. Maybe that might help a little bit. We'll do the couple questions, and then we'll see where we're at. And I'll show you some cadavers before we wrap up. All right, cool. Okay.